The document provides a comprehensive overview of potentially inappropriate medications, PIMs, for older adults, greater than or equal to 60 years, and highlights concerns, alternatives, and recommendations for safer prescribing practices. Below is a summarized version of the key points, key concerns in older adults. 1. Increased sensitivity to medications. Older adults are more susceptible to adverse drug reactions, ADRs, due to age-related changes in pharmacokinetics and pharmacodynamics. Common risks include cognitive impairment, delirium, falls, fractures, orthostatic hypotension, and sedation. 2. Polypharmacy risks. Concurrent use of multiple CNS active drugs, for example, benzodiazepines, opioids, anticholinergics, increases the risk of falls, fractures, and delirium. Deprescribing or dose reduction is often recommended to minimize risks. 3. Drug-disease interactions. Certain medications can exacerbate conditions like dementia, Parkinson's disease, heart failure, chronic kidney disease, CKD, and urinary retention. Medication-specific concerns. 1. Acetylcholinesterase inhibitors, ACEs, donepezil, rivastigmine. Avoid in bradycardia, syncope, or orthostatic hypotension. Side effects: diarrhea, nausea, weight loss, urinary incontinence. Alternative: memantine. 2. Benzodiazepines, alprazolam, clonazepam, diazepam, lorazepam. Increased risk of cognitive impairment, delirium, falls, and fractures. Avoid in dementia, history of falls, or fractures. Exceptions: seizure disorders, severe anxiety, or end-of-life care. 3. Non-benzodiazepine hypnotics, for example, zolpidem. Avoid in older adults due to risks of ataxia, impaired psychomotor function, and delirium. 4. Antiplatelets and anticoagulants, aspirin. Avoid for primary prevention of cardiovascular disease, CVD. Warfarin, higher risk of bleeding compared to DOACs, for example, rivaroxaban, apixaban. Avoid combining with amiodarone, ciprofloxacin, or SSRIs. DOACs, preferred over warfarin for non-valvular atrial fibrillation and VTE. 5. Tricyclic antidepressants, TCAs, amitriptyline, clomipramine, imipramine, strong anticholinergic effects. Avoid in dementia, delirium, or history of falls. Risk of orthostatic hypotension, urinary retention, and sedation. 6. SSRIs and SNRIs, paroxetine, citalopram, escitalopram, duloxetine. Risk of hyponatremia, falls, and QT prolongation. Citalopram greater than 20 mg/day, escitalopram greater than 10 mg/day. Avoid in dementia or with concurrent CNS active drugs. 7. Antipsychotics, haloperidol, quetiapine, risperidone. Avoid for behavioral problems in dementia due to increased risk of cerebrovascular events and mortality. Use only if non-pharmacological measures fail and patient poses a threat. 8. Antiepileptics, gabapentin, pregabalin. Avoid combining with opioids due to risk of severe sedation and respiratory depression. Use with caution in CKD, adjust dose. 9. NSAIDs, ibuprofen, naproxen, diclofenac. Avoid chronic use due to risks of GI bleeding, peptic ulcers, and kidney injury. Use with gastroprotective agents if necessary. 10. Opioids, morphine, oxycodone, tramadol. Increased risk of falls, fractures, and sedation. Start at 25 to 50% of the usual dose and monitor closely. 11. Anticholinergics, oxybutynin, tolterodine. Avoid in dementia, delirium, or urinary retention. High risk of cognitive impairment and sedation. 12. Antihistamines, diphenhydramine, hydroxyzine. Avoid due to strong anticholinergic effects and risk of delirium. 13. Proton pump inhibitors, PPIs, omeprazole, esomeprazole. Avoid long-term use, greater than 8 to 12 weeks, due to risks of Clostridium difficile infection, pneumonia, and fractures. 14. Antidiabetic agents, sulfonylureas, for example, glimepiride. High risk of hypoglycemia. Prefer short-acting agents, for example, glipizide. Insulin, sliding scale. Avoid due to increased risk of hypoglycemia without improved glucose control. 15. Corticosteroids. Avoid in patients at risk for delirium or GI bleeding, especially with NSAIDs. 16. Antiarrhythmics, amiodarone. avoid as first-line treatment for atrial fibrillation due to toxicity risks. Digoxin, avoid as first-line therapy for atrial fibrillation or heart failure, do not exceed 0.125 mg/day. General recommendations. 1. Deprescribing, regularly review medications and consider deprescribing if risks outweigh benefits. Monitor for withdrawal symptoms or clinical worsening after discontinuation. 2. Individualized approach, tailor medication choices based on patient-specific factors, for example, kidney function, cognitive status, fall risk. 3. Non-pharmacological alternatives, prioritize non-drug interventions for conditions like insomnia, anxiety, and behavioral issues in dementia. 4. Monitoring, regularly monitor for ADRs, electrolyte imbalances, for example, hyponatremia, and drug interactions. Conclusion, the use of PIMS in older adults requires careful consideration of risks and benefits. Deprescribing, dose adjustments, and safer alternatives should be prioritized to minimize adverse outcomes and optimize patient care.